Thanks for the introduction. So kind of over the past year, kind of suction and ureteroscopy has really kind of overtaken everything's kind of, since at least I've been in urology, kind of the biggest change I've seen over such a short limit of time. So last time we kind of talked more about kind of intrarenal sepsis and perioperative factors, but I want to go delve a bit deeper in kind of the suction that's kind of really developed over the past year. Looking at some of the advances with the suction catheters and some upcoming scopes. And as we're doing more complicated and longer ureteroscopies, it's important to be aware of some of the surgical ergonomics and endourology and some of the new up and coming robots that have tried to alleviate some of these concerns. So as we all know, stone disease is very prevalent within the population and its rates are increasing. Even the gender gap between men and women is also leveling out. It's very common. Once you do have stone disease, half people do have recurrence within 10 years. And direct and indirect costs on the patient and healthcare systems are more than 5 billion USD a year for the United States. Per the guidelines, ureteroscopy is the mainstay of surgical treatment with high stone-free rate and lower complications. It's considered first line for ureteric stones, renal stones less than 2 centimeters. But some of the studies may show that we might be starting to do some larger stones with these, also for pregnancy, peds, and comorbid patients as well. So this is a graph showing the relative proportion of stone cases that are done ureteroscopically. This is a bit dated, but only goes up to around 2017. But they did see a increase from around 46% of stone procedures in 2007 were done ureteroscopically, and then in 2017 that increased around 60%. I think if it continued kind of another 10 years to now, you probably likely see even greater increase, especially over the past year. A lot of these are due to improved visualization and maneuverability of your scopes, the advent of single-use scopes, better laser, and now suction. If you looked at the similar graphs for PCNL and shockwave, they've seen relative stability of PCNL procedures, but shockwave has dramatically decreased over the years. The EAU guidelines is the only one of the kind of 3 main guidelines that touch specifically on complications associated around ureteroscopy. There's a complication rates around 4 to 25%, with post-operative urosepsis rates around 5%. A lot of that work was done by the Stone Center here, which I'll touch on in a bit. Ureteral avulsion and stricture rates are fairly low, less than 1%. And it mentions kind of high intrarenal pressure does predispose to complications. At the time of the guideline, there wasn't an accurate way to measure it intraoperatively, but I'll show you. There are some new scopes. And it does mention intraoperative irrigation pressures less than 30 millimeters of mercury and unobstructed urinary drainage does help to relieve or decrease postoperative sepsis. They mentioned that in particular for PCNL, but I think it's equally applicable to ureteroscopy. So a lot of the advancements and areas of improvement have looked at trying to improve OR time, improve postoperative pain, lower the complication rates, and improve stone-free rate. And a lot of this has centered around looking at intrarenal pressure, temperature, looking at suction and scope design. So just a quick review of kind of around intraoperative or perioperative sepsis. This was the first systematic review meta-analysis to focus on urosepsis. In the past, I used a very heterogeneous definition, ranging from anywhere to fever or UTI post-op to actual urosepsis. So this was done by Dr. Chu and Dr. Bojani in Montreal, and they looked at several risk factors to predispose for urosepsis, which defined as infection plus SIRS criteria postoperatively, including almost 6,000 patients. They found a postoperative urosepsis rate around 5%. They highlighted 6 factors, with the most important 3 being preoperative stent insertion, preoperative positive urine culture, and age, but also associated with procedure time and kind of patient comorbidity seen with diabetes and ischemic heart disease. When they further looked at the IBM market commercial database, which is kind kind of very large employer and healthcare plan for 215 million people in the US. They looked at over 100,000 ureteroscopies over a 5-year period, looking at sepsis 30 days postoperatively. They found that if you did develop sepsis, these patients had longer inpatient stays, ICU visits, and average length of stay was almost 2 to 3 times longer than if you were not septic, and also 2 to 3 times the medical costs. I think this is just for their hospital stay. And then when they looked at the further ICD-10 criteria for patients that develop severe sepsis, that's anyone that required sepsis with organ dysfunction, so that ended up in the ICU. Their mortality rate was significantly higher at around 2.5%, compared with 0.82 if you didn't have the organ dysfunction. So there's been a lot of data and trials looking at perioperative considerations, focusing on pre-stenting, alpha blockers, antibiotics, and stent duration that we kind of touched base on last time. But there's been a lot more growing interest on intraoperative findings we can control with temperature, kind of pressure, and irrigation flow. The literature looking at temperature not quite as well developed as that focusing on intrarenal pressure. This is a nice review by Dr. Traxler in Paris on looking at the developing role of temperature. And they believe it's due to the photothermal kind of mechanism that these lasers work. So the fluid temperature is proportional to the laser power, and the tissue damage depends on the temperature and the time exposed. A lot of this kind of literature, I think, stems from those with patients with high fevers, but they're using kind of arbitrary cutoff of 43 degrees Celsius for 240 minutes, and as the thermal dose does increase, the time kind of allowed is much less. So as you increase the power of the laser, the higher power does break up stones faster, but what happens to all the dissipated energy that's not absorbed by the stone, it's absorbed by the water and increases your surrounding temperature. So the temperature also increase depends on the laser power and your irrigation kind of inflow and outflow. And things such as the laser fiber size, addition of basket in your working channel, the type of irrigation, all of this can influence kind of the irrigation flow in your temperature. I won't delve in too deeply, but there is growing evidence that the type of laser itself can affect the temperature, even if you're using the same kind of power between the thulium and the holmium laser. Intrarenal pressure. So the flow of fluid through a rigid tube is influenced by the pressure gradient between the ends, viscosity, length and diameter of the tube. That's Poiseuille's law. And the renal pelvis is also quite distendable. So the transmural pressure depends on Laplace's equation. So if you have buildup of pressure in the system, fluid can start kind of leaking or backflowing to at least 4 different ways from the kidney. So you can have pilotubular, which pacifies the medullary pyramids of your kidney. Pilosinus, if it ruptures the calyx, pylolymphatic, and pylovenous. So baseline intrarenal pressures are essentially 0 in the normal state, but you can see pylovenous and pilotubular backflow occur anywhere over 30 centimeters of water. A lot of the studies kind of looking at this, they will use either centimeters of water or millimeters of mercury. 1 centimeter of water is about 0.7 millimeters of mercury. So these are studies just looking at different animal studies done in dogs and pigs, just looking at what are normal intrarenal pressures in different clinical states. They essentially are doing Whittaker tests on these animals, but similarly unobstructed kidney, like we saw before, essentially normal, but in diuresis states, they can approach around 30 centimeters of water, and with chronic kidney disease, over time, the pressures can get quite high to around 60 to 90. Pylovenous backflow is kind of essentially the earliest backflow mechanism you see with the lowest pressures at around anywhere from 40 to 50. And with pilosinus backflow occurring higher up from 80 to 90 centimeters of water. And on histologic studies, they've seen cellular injury within an hour by looking at contrast dye that kind of leaks into the surrounding cell tissues. Looking at kind of what this means for kind of real world kind of clinical cases. This was a contemporary review looking at 12 studies, looking at different inflow and outflow, things that can affect your intrarenal pressure. And no study reported increases in complication when your intrarenal pressure was less than 30 millimeters of mercury or less than 20 millimeters of mercury for 10 minutes. But I think a lot of the guidelines of the study try to target that 30 millimeter of mercury as the kind of the sweet spot that you want to stay under. And while looking across all the different endourologic procedures, there was a large variability seen. And also, even within the same procedure, you do have spikes in your intrarenal pressure as well. So this is a good review by Dr. Krambeck, looking at the different things that can affect the inflow and outflow. The AU8 guidelines does suggest you make every effort to maintain low intrarenal irrigation and pressures to avoid high consequences. So inflow, depending on your type of irrigation, compared with gravity or continuous pressure or manual irrigation. Studies have found that manual irrigation with a hand syringe, you do see your highest spikes and highest average intrarenal pressure. Having an instrument in the working channel itself will also affect your inflow. Using smart irrigation systems, some of which are up and coming, which is able to kind of sense the pressure and automatically adjust your irrigation pressures, can be helpful. And for outflow, they talk about ureteric access sheaths. The larger your sheath, kind of the better for your outflow. The positioning is also important. Positioning in the renal pelvis or past the UPJ if possible. And considering bladder drainage if you don't have a sheath in. The time of them writing this, their Petra sheath wasn't available, but that would kind of also affect your outflow. And basketing versus dusting, this is more expert opinion, but they find that basketing probably leads to less intrarenal pressure due to constantly removing your scope and allowing fluid to kind of flush out. And then here's a similar kind of flow chart, but for minimizing intrarenal temperature. You can see a lot of the inflow and outflow are essentially the same things that can help, but a lot of it has to do with kind of lasering, where you're lasering your energy setting. So it's important to use either cooled or room temperature irrigation to keep things cool, to deactivate the laser intermediate so you're not constantly firing. Similarly, basketing, if you're doing more basketing, you're probably not firing the laser as much, using the lowest effective power. And as we touched base earlier, there may be some differences in the temperature generated between the holmium versus the thulium laser. And also where you're lasering the stone can also kind of affect the temperature. If you're lasering in a very small calyx with a thin infundibulum versus in the renal pelvis where there's more of a kind of heat sink effect with all that excess fluid. So all of the interest around kind of temperature and pressure over the last year has really led to kind of the development and taking off of all these suction devices in the past year. So there's been a lot of the studies have shown we've been able to decrease the residual fragment size, help improve intraoperative visualization, decrease the need for using basketing or basketing in general, and help improve your temperature and pressure. There are kind of three main different avenues for suction to be able to suction intraoperatively. Initially, they developed these steerable suction catheters, but that's kind of since to move on to the flexible suction ureteral access sheaths, and some of the up and coming are the direct in suction scopes. This steerable ureteroscopic catheter was kind of one of the initial devices. This was developed by Calyxo and called the CVAC system. That'll be important because it'll come back a bit later. And it's essentially kind of a pollock. It's a 7 French pollock, which they have this knob on the bottom that they're able to rotate, and it will kind of change the deflection at the tip. So they did their ureteroscopy as kind of as standard as you normally do. And then at the end, you would feed this under fluoroscopic guidance and maneuver it into your calyces and suck up all the dust. And they found you could suck up to 2.5 millimeter fragments. In their initial kind of pilot study, they had 43 patients with pretty large stone burden, just under 3 centimeters. And they found that stone clearance based on stone volume, they were able to decrease 94 to 99%. Of these 43 patients, 21 patients had anticipated stage ureteroscopy as per their preoperative consult. However, only 2 patients required further intervention. This was recently published by their same group looking at 30 days results of their Aspire study, which was comparing that cerebral catheter, suction catheter with standard ureteroscopy. This was a multi-center non-inferiority study done across 11 US centers. And these patients did have 30-day CT follow-up. Even though it was randomized, the ureteroscopy group did have slightly larger baseline stone sizes and volumes. But what they found is the stone-free rate at 30 days was equivalent between the 2 groups at around 50%. But they did find better stone clearance when you looked at the volume of stone reduction. They found with the suction catheter was around 97% versus 93% in the ureteroscopy group. And residual stone volumes were much smaller at around 14 milliliters compared with 70 in the ureteroscopic group. They found that safety was comparable. And on their sub-analysis, when they looked at volume of stone clearance compared with baseline stone volume, in the suction catheter group, it didn't really change depending on the baseline stone volume. But with ureteroscopy, you do have a drop-off as you get to treating much larger stones. So the next category is the suction ureteral access sheath. The main one we've been kind of using the past year is the clear Petra. And this essentially kind of replaced all our standard sheets from before. It has this offshoot at the side, which attaches to the wall, and you get passive suction with that, and a slit you can activate increased suction. And it has a flexible tip at the end that does deflect with your ureteroscope to kind of go into all your calyces when you're treating the stone. A lot of this work was initially developed in China, and so a lot of the early work was done there. This was a retrospective review of 200 patients comparing the clear Petra with standard ureteroscopy, and all the patients had 30-day post-op follow-up either with KUB, and if they were suspicious for stone, they got a formal CT looking at stone-free rate. So with this, although 40% of their patients were pre-stented, mean stone size slightly under 2 centimeters, and about a third of these patients had multiple stones. They did find with the suction ureteral access sheath, they had slightly shorter ORs, improved post-op day 1 stone-free rates and post-op day 30 stone-free rates. And interestingly, they did find significantly improved infectious complications, 9% versus 20%, which does seem a bit high to me. Locally, we've been doing a lot more ureteroscopies on larger and more complex patients. This was a patient previously had a very difficult access for a PCNL, given the high kidney, and had some complications post-operatively. So the patient was brought back for a ureteroscopy with a clear Petra. So as you can see, you're able to get the sheath right up to your stone. You're able to do a lot of your lasering in the sheath, which does kind of protect the surrounding mucosa. And it also, with kind of the sheath fixated on the stone, it does help prevent some of the respiratory movement. And a lot of it is kind of once you fragment the stone, you can kind of dust the stone just in the sheath and then suction it all out. And here's a look at kind of at the end of the procedure where all of that dust and everything that you would have normally is all kind of sucked away. So it does help improve your visualization. You're able to get these patients endoscopically stone-free. And it's less, and then you're not worried about leaving larger fragments hidden in the dust. So a lot of this with the suction, the other part of it is being able to measure the pressure. So a lot of the recent advances, you had newer scopes that are able to sense both the pressure and temperature. But a lot of the newer single-use ureteroscopes, they have smaller scope sizes, which also helps increase the irrigation flow around it, allows you to use smaller access sheaths without losing on that irrigation flow. So just a quick review, the LithoVue and the LithoVue Elite, it's been available for the past couple of years. A lot of the work did come out of the Stone Center here looking at sensing pressure. So initially it's done in a porcine model, and the scope's able to sense a real-time measures around 4 times a second from the tip of the scope. In the animal models, it did find that intrarenal pressure was highest when you had no access sheath. Intrarenal pressure was highest when the sheath was placed at the UPJ and lowest in the renal pelvis. And intrarenal pressure was highest when you were using manual syringe irrigation. The first in-human experience using the LithoVue Elite was done here in Montreal, and 46 patients with pressurized irrigation. They found that the median intrarenal pressure was just at that 30 millimeters of mercury cutoff, but they did see spikes almost up to 180 millimeters of mercury. But the pressure was less than 60 millimeters of mercury in less than 91% of cases. We found that patients without ureteric access sheaths and tight ureters did have longer longer time exposed to higher pressures. And the larger access sheaths did decrease the intrarenal pressure more than the smaller access sheaths. So at the time that study was done, Clearpetra wasn't available yet, but recently we kind of repeated that study using the Clearpetra to see what effect that had on the intrarenal pressure. So this was the retrospective study we did here, looking at 25 consecutive patients comparing ureteroscopy with the Clearpetra. We did treat renal stones up to 2 centimeters using either the 11-13 French or 12-14 French size sheaths, and irrigation pressure of 250. And this was done with the LithoVue Elite with a real-time intrarenal pressure monitoring. So with these patients, median stones treated per case was around 3, with a stone volume of around 380 mils. There has been a trend to use kind of stone volume as instead of stone size. It gives you a better sense of the work that you're doing with lasering. It was about 11 and 13 French sheaths were used in around 64% of patients, and they were able to advance the Clearpetra to the calyx of treatment in around 72% of patients and into the renal pelvis around 28% of the time. Here's looking at the percent of each procedure that you spend in the different intrarenal pressure ranges. They found the median intrarenal pressure was around 22 millimeters of mercury, below that 30 millimeter cutoff, and intrarenal pressure was below 40 millimeters of mercury 76% of the time, and below 60 millimeters of mercury 94% of the time. We found that lower intrarenal pressure was associated with prior endourologic procedure, pre-stenting, larger ureteric access sheath, and preoperative alpha blocker use. There was one readmission for sepsis requiring IV antibiotics postoperatively. But we did find smaller size sheaths that may be less traumatic and more likely to reach the stone. And since then, we kind of just switched to only using the 11-13 French sheaths. We found the 12-14 French, sometimes it's hard to get past a tight UPJ, and it was occasionally may have been more likely to cause some ureteral injury anecdotally. And finally, the third category of these scope suctions is kind of having the suction built into your scope directly. This is also called the CVAC scope from Calyxo. If you remember, that steerable catheter we talked about earlier was also called the CVAC. They essentially rebranded it to this, and their website has very little evidence of their prior product now. So I think this is what they're focusing on now. But this has a 7 French working channel in the middle, and this is housed within a fairly large scope at around 12 French, I think 11.9. And it has passive aspiration. During lithotripsy and afterwards, you can remove all your instruments from the working channel and essentially suck up the fragments through that 7 French working channel. They have a very fancy rendering of the device on their website. Let's see if that plays. Yeah, so you're able to kind of laser the stone and it'll actively suction all the fragments. And then afterwards, you can activate the active suction to kind of suction everything out as well. And this can be used in combination with a normal kind of Clearpetra access sheath as well to help improve your suction. But while I was just putting together this presentation, I saw this FDA warning kind of posted last week, saying that there is a risk of injury in patients with high viscosity urine. They had one patient-related death where the patient had very thick urine that actually plugged up their suction port, and then they had kind of unobstructed inflow. So they recommend stopping the irrigation if things get cloudy, turbid, or thick fluid, and you can use it in conjunction with a larger access sheath. So that scope being almost 12 French, you definitely have to use at least one of the 12-14 or 13-15 access sheaths, 11 and 13. The scope may not even fit through that. So there are some upcoming studies looking at this next generation of the CVAC scope done with Mayo Clinic in Arizona. Here at UBC, we're also part of that trial, contributing some of the Clearpetra data, comparing that to the new CVAC scope. And they're looking at ureteroscopies with patients with larger stone burden, so over 1.5 centimeters, with preoperative and postoperative CT, and looking at primary outcome of volume of stone reduction. So some of the preliminary data from just us here locally, looking at patients with 30-day follow-up and greater than 1.5 centimeters stone burden. We have around 12 patients. Of course, these patients are a bit more biased because we don't routinely get postoperative CT on all our patients. So the ones that we do organize, they're generally more complex, more comorbid patients. The cases where we feel like we treat all the stone endoscopically with nothing left over, those we tend to follow with just KUB and ultrasound. So this is definitely a bit complex population. But from those 12 patients, they did have initial stone burdens over 4 centimeters. But we were able, their mean stone volume decrease postoperatively almost 90%. But as you can see at the bottom here, mean operative time of around 2 hours. So there has been a trend that we are doing these longer and more complex ureteroscopies, some of them approaching the 2 to 3 hour mark. And then there's been a lot of data where you can see that they're really trying to push kind of what you can do with ureteroscopy with suction, comparing it a lot to mini PCNLs and even to some PCNLs where you're almost operating on full-on stags with suction. And I won't delve too much in detail for this study, but a lot of the studies, what they've shown is either, this one showed no difference in OR, but kind of clinically from us using it, I do think there is increase in OR length, but stone clearance rates have been similar, and there have been lower complication rates because you don't have that percutaneous puncture. So where all of this is going is, as you're doing these more complex, longer cases, I think it's important to review some of the ergonomic factors, because sometimes after these long cases or the next day, I really do feel it in my wrist at the end of the case. So ergonomics, it's the concept of designing the working environment to fit the worker. Workplace-related MSK disorders, it's when the work contributes to significant conditions, and the work that you do can make these conditions worse or last longer. So these high-risk activities are listed by the Bureau of Labor just for any workplace in general, and they list high-risk activities as those with repetition, prolonged exertion over 30% of your strength, body segments held in extreme position, prolonged static posture, activity with vibrating tools, and exposure to cold. So except for exposure to cold, I think all of these are applicable to endourology cases and operating in general. I guess if you turn the temperature down in the room real cold, you kind of fit all of these criteria. So doing these endourology cases can really be at high risk for MSK-related disorders. So they found on surveys that these MSK disorders related to surgeons and interventionalists, a lot of these center around kind of neck, lower back, rotator cuff, and wrist injuries. Many surgeons will decide to work through it, but 12% do end up taking leave, modifying their practice, or may lead to early retirement. So there are large implications on caseload, practice pattern, and career longevity. And a lot of this is just focused just on the OR, but then you're stuck with your after hours compounded with you hunched over your laptop, checking the labs and going over your inbox, and really kind of add on to that as well. So the American College of Surgeons found that of about 40% that sustained these workplace MSK injuries, only 50% of them received medical care, and only 19% of these surgeons reported it to their institution. An international survey of around 86% of urologists did experience MSK complaints in the past year, with 49% of these turning into chronic long-term complaints. And they found that if you did endourology or laparoscopic procedures, you were at higher risk compared with your other surgeons. So they found that risk factors for these workplace MSK disorders were younger age, hand-assisted technique, is that the surgeon was shorter height, female, smaller glove size, both the patient and surgeon's BMI, the surgeon's medical comorbidities, and surgical volume. They found that exercise, the number of years in practice, and older age were more protective, given that if you're more experienced, you've kind of felt ways to kind of dealt with this and kind of adjust. Yeah.
It's like low side.
Mm-hmm. Yeah, definitely. And
what about teaching center? Was that at all in there?
I don't think that was one thing they looked at.
Okay.
And the older age thing is probably some degree of survivorship bias too, right? Because
a lot of the ones
who are just have like more robust,
they get
carpal tunnel.
earlier.
Well, that's why I was asking about the teaching thing, because you're standing behind them they're doing it a lot. So
Yeah.
you're not.
It's
like,
true, although the cases are more complex.
Yeah, that's could be true too.
And there's been a lot in the literature already looking at open laparoscopic kind of ergonomics, but we'll focus on more specifically endourology, where you have unique because you have prolonged static position and repetitive movements. You can develop a wrist and thumb strain. There is the added kind of foot pedal you're using, dealing with several different monitors in the room, and also kind of wearing lead. So as your cases do get more complex and longer, all of this can start adding up. Different survey found that 69% of endourologists that complain of workplace-related pain or shoulder, mostly affected neck, back, shoulder, and hand.
Hey, Runhan, are foot pedals good or bad?
I get into that in a bit.
Do you? Okay.
So kind of long debate, sitting versus standing. I've seen both depending on where you go. When you're standing and trying to use the foot pedal, you load your body weight on your opposite foot, and then your foot's kind of hovering over the pedal, which can put kind of strain on your hip and also disrupt your balance. When sitting down can help some of this pressure, but then you're kind of disrupting where your monitor placements are and kind of the height and everything for the assistant. Ideally, you want to place the foot pedal directly in front of you to prevent sliding and prevent overreaching. Monitors you want in line of sight with you, ideally within kind of a meter in front of you and in line with your endoscope. The center of your screen should be just below eye level, just to help minimize eye strain. And then they want your neck and ideally should be the same alignment as your body. And one important thing is try to optimize your monitor layout. Sometimes when we're in those ORs, you have 3 different images on 3 different screens. Ideally, kind of using picture-in-picture so you're not constantly turning your neck to look at the fluoro, and making sure that the settings are optimized to help reduce eye strain for the different settings, depending on if you're doing rigid or flexible scopes.
I have another comment on that. Also, like the C-arm to get under the table when you're 5'5", like max, like there's no way you can have your eyes looking at a TV screen at the same ergonomic you're mentioning. It's just physically impossible, and just your hands are sitting in the air because you're not like the patient is so high. But it's just like one kind of like comment in terms against how like it's not possible for people
definitely.
like looking like me like to do those with ergonomic sittings. One question I have otherwise is the sitting position. Again, I don't know how I could be sitting and seeing something, but interesting. What about scattered radiation in terms of your position? I will believe that sitting is not good for your eyes and cataracts and
I
cataract.
think sitting, your face is much closer to the source and the scatter. And then I think if your lead gown is like your crotch is kind of open to the source, but yeah, so I think a lot of these I think a lot of the recommendations I kind of make in silo depending for each specific recommendation, but when putting it together it can be quite difficult with kind of a lot of the things that Dr. Saint Laurent mentioned. So what a lot of the studies, what they found that the lighter scopes are actually better. The single use and digital scopes do tend to be less weight than your reusable scopes. And then those are also the scopes with better image quality to help reduce eye strain. Your scope should be slightly adducted to the side of the chest and rotated inward at shoulder level, elbow flex, kind of in neutral position. But a lot of this can be very hard if you're dealing with difficult stone, difficult kind of kidney anatomy. You need appropriate irrigation system for visualization. And if you're standing for a long period of time, having anti-fatigue floor mats. And also the type of lead you're wearing. A two-piece lead does distribute weight better over your shoulder and hips rather than that single kind of apron that's just putting a lot of weight on your shoulders. And then there's also the component of radiation safety. I won't dwell too much on that, but that's kind of its own separate issue. There's been studies looking at what specific muscles are activated during your ureteroscopy, where they attach these surface EMGs and get surgeons to do these ureteroscopy simulations with a variety of different scopes. They found that the thinner group, so the muscles in your wrist and the extensor carpi ulnaris in your forearm were the most activated. And they found that the digital, so the lighter ureteroscopes did have less muscle activation. The extensor carpi ulnaris, it's the one that, I did have to look that up. It's the one kind of laterally in your arm. It's the one if you overuse leads to tennis elbow. I don't know, they're all kind of in the same area, but it commonly leads, it's a muscle that gets injured when you play a lot of tennis. At the Cleveland Clinic, they also looked at differences between genders and male and female. They did kind of similar study with EMG surface activity between male and female surgeons and also between trainees and junior staff. They simulated procedures for those for ureteroscopy navigation, dusting, and basketing. They found that women across the board had more muscle activation on their surface EMGs, and then women reported greater subjective physical workload. And then similarly, they found that reusable scopes did have greater muscle activation as well. They found no correlation between the training level and level of muscle activation. But they only they only went up to junior staff, so it's hard to say if they included more senior staff if they would change anything. So how do where do we go from there?
Has anyone looked at sort of the effective experience on the type of muscle activation that you have? Because I feel like as you get more senior and you do this a lot, you learn ways to hold the scope that is less fatiguing. And sort of a corollary to that question, and I'm curious about Ben and Ryan, when I train the residents, I'll sometimes talk about how you try to keep as much as possible your anatomic position and your elbows by your side. So even when your scope is rotated really far around, instead of holding that position where you're like this, you turn your body in your hand and you try to hold the scope in maybe a non-traditional way, but it's going to reduce the strain on your. You guys do that? I think I learned that from you, probably.
I think it's really hard when you're learning because you're just so focused on that and you're going to do whatever you need to do to get your scope to do what you want to do. And if this involves doing this for a long time and then later on at night you're sleeping, you're like, oh my God, my hand hurts. So I think you're right. And I think it's up to us to really kind of point this out. Table height, all these kind of
A lot of
things.
these studies were what kind of these simulated like desktop models that to me didn't look that complex. But I definitely agree. Either like changing your hand grip or even using your other hand sometimes can really help. So that kind of leads into this last section I want to touch on.
If I can, sorry to interrupt, Joel Teichman here. I just want to echo Connor's comment, having done this for the better part of 30 years. And that is, there's no question that when I'm looking at junior residents or younger, what I call rookie ureteroscopists, that they start torquing their entire torso as they're trying to make these maneuvers. They're often so focused on what the task at hand that they've stooped their shoulders and head into the patient's crotches if they're trying to get closer to the action, instead of standing bolt upright in a relaxed position. And if you look at someone who does ureteroscopy for years, the maneuvers are so subtle and far less motion in displacement of their arms. And it just seems so much easier. It's like looking at an expert surgeon or laparoscopist who barely moves their hands and their arms because the maneuvers are subtle, whereas a rookie tends to make grotesque big maneuvers which put much more strain on their body.
Thank you for the comment, Dr. Teichman. So if we're doing more ureteroscopy, how do you do ureteroscopy without actually doing ureteroscopy? You get a robot to do it. So that's kind of the last part of this talk I want to briefly go over. There's been a lot of new up and coming developments by trying to alleviate some of these ergonomic factors. This is the ILY robot from Sterilab. It has this ergonomic wireless joystick controller, similar to an Xbox or PlayStation controller. This was presented by Dr. Chow Rebet from UC Irvine at AUA last year, and they had their first prospective clinical experience. They can use a variety of different access sheaths and scopes. They did 31 cases, mean OR time around 83 minutes. You do have to get the access first, put up your sheath, and then that's when you dock the robot. But docking and draping only took around 8 minutes. And then their kind of 30-day stone-free rate was around 94%. So here's a video of them using the robot. As you can see, he's using the controller. He's even taken his one hand off of the controller and looking off to the side. So it does kind of make things quite easy. So it's essentially turning it even more into a video game. And yep.
Is it more similar to like an Xbox? Just like a curiosity thing.
It looks more like a PlayStation.
Yeah.
With the robot companies, they were getting some engineers to help design the interface to control it. And then they realized, they said, you know what, the game companies have spent millions of dollars trying to design an interface, and this is already it. So that's why they just went to it. And I don't know if you're going to talk about the Oris robot, but essentially it was an actual Microsoft Xbox controller that they just kind of hijacked.
This is the Zamanex robot by Rowan, a Korean-based company. They just recently did their first clinical live demonstration back in January in Thailand. And this is the first AI-based stone surgery robot. So it's able to compensate for respiratory synchronization. It has stone size guidance. So while you're looking at a stone fragment, it's able to estimate the size of the fragment and tell you if it's too big to basket out. And also has path recording. So if you once you basket a stone, it actually remembers where you are. So you can press a button, it'll automatically basket the stone out for you and even remember where you are, and it'll go right back to this calyx for you automatically. And a lot of these robots allow your surgeon to be much further away from the operating field. So it also helps, keeps you safe from a radiation point of view. And it has this one has this unique kind of two separate controllers, where the left hand is more like, if you remember back to the kind of, we were talking about video games, more similar to like the Wii Nintendo Wii like remote control on the one side, and on the right hand, it's it's more this kind of lever and pulley system, which gives you better fine control with everything in a neutral position. They actually have demos for this at the upcoming AUA if anyone's interested in testing it out. And then the last robot I want to talk about is the Monarch robot that's recently kind of been purchased by Johnson & Johnson. And this is more of an endoscopic combined for endoscopic combined procedures, so similar to like a mini PCNL, but it contains of 3 robotic arms, a fluid management system, and a display tower. So your bottom 2 arms, it holds your ureteroscope and your sheath, and then the tip of the ureteroscope is able to generate electromagnetic field, and this can be sensed by your 3rd arm, which is up by the flank. So this was presented by Dr. Landman at UC Irvine on Urology Today website. And your puncture needle also has electromagnetic sensors, one at the tip and one at the end. So it uses these 3 points to help you align your puncture site. And essentially, you're just aiming for that to target that little bubble right in the middle of your target to get the bullseye. So I'll play it again. So as you're once you landmark it on the skin, as you're moving around the needle, you're essentially just aiming it for the middle of the target and then advancing it head on right into your papilla that you're looking at with your scope endoscopically. And then after that, they're able to put in the suction catheter at the back, which essentially is helping to suck out a lot of the fragments as you're lasering ureteroscopically from down below. And this is all controlled from their gamepad controller that you're able to switch between the 2, the one in the back and then the one ureteroscopically. So they recently published their first prospective first in human trial with 13 patients. They successfully completed the procedure in 12 out of the 13 patients. Their power cord broke, I think, on the last case, and because it was a prototype, they didn't have a replacement. But these were treating very large stone burdens, greater than 3 centimeters. And in each case, which I found quite interesting, was they were able to get percutaneous access with a single pass each time within 2 millimeters of the center of the papilla each time. Average OR time was a bit over 3 hours, which I think is could be expected given the stone burden. But actual robot docking and setup time is quite short. At 1 month CT scan follow-up, they had 98% stone volume reduction, and it was very low comorbidity, only 1 UTI requiring subsequent hospitalization for antibiotics. So in conclusion, suction ureteral access sheaths can help reduce intrarenal pressure and stone fragments. It's been a lot of new single-use ureteroscopes and upcoming direct insuction scopes coming up. And with this increasing complexity and duration of ureteroscopy, I think it's become increasingly important to be aware of the aspects of surgical ergonomics. And there are some upcoming robots that can help alleviate this, but the main issue with these, the actual cost of these robots, and a lot of these being single-use kind of things, really will have to be determined. Thank you all, and open to any questions.